I don't want to say it so bluntly, but almost seems like healthcare is throwing family members breadcrumbs to just delay the situation from happening.
Yeah.
Because they don't know how else nicely to put it.
Yeah. Sometimes more options isn't always the best. I know we like to have different flavors of ice cream, but cold status is probably not the place to have multiple flavors.
I gotta go. I've been working, told them please don't hit my phone. I'm in my zone, bruh, just leave me alone. Was on the road, but I swear I'm coming home. Now the drinks on me, I think we need a toast. See, I did it for me. Now my old friends calling, told them nothing's for free. Told me time is money, dog, swear I paid all my fees. I was starving for this game, now my family can eat.
Hey everyone, welcome to the Cup of Nurses show, here with your hosts Peter and Matt, and we are on a mission to change the world, one conversation at a time, so let's jump right into it. But before that, if you find value in the show and want to join us on this mission, please share and review the show. It would mean everything to us. cupofnurses.com for the latest information, updates on what we're up to, and the latest merch releases. For our lifestyle podcast and conscious movement, check out wearefrontlinewarriors.com.
In this episode, we're going to talk about the ethics of different code statuses. Should people have an option to be a partial code? Is there any benefit of a partial code? Many people think that there should only be two options. Either we do everything as a full code or we do nothing as a no code.
And this episode was inspired by an experience that we had a couple days ago working in the ICU. We've had an episode about code statuses before, but I think it's time to discuss the ethical dilemma that we see here in partial codes ultimately. So when it comes to code statuses, the main thing we want to know about this situation is what is your code status, right? But ultimately what it stems down to is the quality of life that you're trying to have. Depending on different cancers, different progressions of disease you might have in the hospital, we bring up code status to family members multiple times. Usually palliative care does it, depending on what's going on, if they need dialysis, if they're gets diagnosed with cancer, and etc. So main thing we always want to look out for is the quality of life that the patient's going to have. We can do a lot of procedures as always, extend life, put a trach in, put them in a nursing home, but is it always the right thing to do?
Yeah, another gray area of nursing for sure. Because before the, you could say, creation or the allowance of partial codes, there was either you're a full code or you're a no code. Now people have become a little bit more specific on what they want done. They're given more options. Like Matt said, you could either be just medication. So if your heart were to stop, then all we really do is push meds. Or it could be no CPR, but it's okay to intubate. So we would intubate you and push critical life-saving medication. So that's another option. But like you said, the thing is the quality of life, because time matters. Every second there are cells dying, and every second that your heart is not beating, you're not being perfused. Because we even had a discussion prior to this episode. If you have no circulatory system activation going on, so your heart's not pumping, is there really any kind of action transportation going on between the blood and the tissues? There isn't, because you mentioned that there's the pressure. You have to have the pressure. Without the pressure, you don't have the whole cascade of other events that require oxygen to move from the blood to the tissues, and then CO2 from the tissues to the blood.
AKA cell death. And I'm thinking about partial codes. We could touch upon that full code status thing, or the full code blue that happened. Sometimes code statuses can be beneficial when it comes to partial. When, let's just say, I want to be a full code and I'm going to be on BiPAP. Okay, there's a chain of event that's going to happen. If you're a DNR, we're probably going to transition you to comfort measures ultimately. Or maybe when your heart stops beating, you'll be a DNR. But if it's the DNI situation, do not intubate, let's just say, okay, you're on BiPAP, maxed out on support. The only thing that's going to help you now is the vent. You're gasping for air. You're getting tired as hell. Patient doesn't want, or family doesn't want to intubate. All right. Well, eventually this patient's going to get exhausted, maybe go into VTAC, go into PEA, and we're going to have to start a code. So we're going to do compressions, do meds, let's just say, but they don't want to intubate. Well, part of the whole code is to establish an effective airway so we can actually perfuse your cells, because the whole point of saving your life is for you to have the best quality of life when you get out of this procedure. So now that we're not intubating, we're still doing everything else except for that one component. What if we didn't perfuse it properly during CPR in the whole code and it led to an anoxic brain injury? So that's where it's such a gray area, just like you mentioned, because we really want to do the best for the patient. So I think giving this ability to have partial codes, I think it should be discussed more specifically and more precision based on every single patient.
Yeah, just to throw some numbers here at you guys and stats. If you cardiac arrest outside a hospital, your chances of coming back alive and surviving is 12%. And that's with no intervention, you could say. So there's a small chance that you're going to, you could say, almost reattain your heartbeat by itself, just intrinsically, for whatever reason that happens. If you throw in CPR into it, your survival rate goes from 12% to about 24 or 36. So just doing CPR doubles and triples your chances of coming out of that cardiac arrest alive. If you code outside a hospital, like I said, 12%. In hospital, so if you cardiac arrest in hospital and we're all there on standby, your chances of living, it goes up to 25%. So CPR itself is helpful, but even without CPR, even with and without, your chances of survival are still about 25%. So it's not high. So so this is why in medicine we try to prevent this cardiac arrest, because a lot of people don't know that once you cardiac arrest, you have about 12 to 36% chance of surviving, which isn't much. So we literally try to do every single thing to keep your heart from not stopping. If you go bradycardic, we give you atropine. If you go into a VTAC, we want to slow it down so then your heart doesn't stop itself from beating, you could say, from being overworked. So we try really hard to avoid these situations, because this is the worst situation you're going to be in, or your loved one, and it's what we want to prevent, because other things are more reversible, are easier to reverse than cardiac arrest has about a 12% to a 36% chance of survival.
Not to mention the survival rates when you have increased morbidities, obesity, a type of cancer, a chronic illness that's affecting you. Your chances of survival are average from 5 to less than 1%, respectively. So it's not looking good. We want to prevent that to happen. But just because we kind of jumped around here, so to define code status, if a patient gets admitted to the hospital, we want to know that thing right away. When I'm getting a patient and I'm admitting it and I'm looking into the ER notes, I want to find out what the code status is, because for the healthcare team, we want to know how we should treat you, what procedures we should do, because we want to respect your wishes. So that's the main thing of knowing your code status.
And we don't want to know it because, for example, we think you're going to code. We just want to know it because it's always a possibility. It's always in the back of your mind. Like a just in case, because there's not like people that code in a hospital. It's not like, especially here where we're at, it's not like somebody codes every day. In other hospitals, it might be more frequent, but it's not something that happens every single day on your unit. So we don't ask for the code status to predict you from coding or predict when you're going to code. We use it as like a sense of direction of what to do when you're not able to let us know what you want done.
And to be honest, the partial code situation, sometimes it gets funny where like night shift begins, and let's just say you're transitioning between shifts, family still deciding, doctor wrote some note, and I had an episode when it was about to be change of shift. My patient went into VTAC with a pulse, and we didn't know what we should be doing. Should we start amio or should we do a shock? What kind of partial DNR status issue? What's the DNR there? And it was just so confusing because in that moment, I couldn't decide, or I couldn't figure out what it was. I literally blanked out the last 15 minutes of my shift, and I had to look it up quickly in the notes. So another gray area that makes it more confusing for us.
Yeah, it's difficult, especially because now we live in a time where people want to shift things for themselves in their own direction. People are, you could say, a little bit more pickier, and as a society we allow for more of this pickiness because we all want to mold these decisions to make it more comfortable for us. Sometimes people need to realize that it's either white or black. A lot of things in life aren't white and black. Maybe this is something that should be white and black because we know how important time is. And this is where like the ethical dilemma comes into play. The main objection to partial code orders is that they are ineffective in sustaining life and can potentially deceive the patient and our family member into believing that resuscitation is possible when in fact the patient's death is imminent. So with these partial codes, it's almost like we allow this to happen just to make the family feel better. But it's one of those things where if you for example, just take the concept of life, for example. You have a full code, which means you're trying to do everything you can to fully be alive. And then you have a no code situation where if your heart stops, then you're just going to be as is and not touch you and not push you in a specific direction. And if now you bring in a partial code, do you want to partially bring you back to life? Because if you decide on a partial code, we're not doing every single thing we can to better your chances of coming out of that cardiac arrest. So that's where it becomes very gray and it becomes a very big ethical issue. Because a lot of times when we partially code these people, let's just say we do intubation and meds only, no CPR, and this patient gets their heartbeat back, they've been down for longer than somebody that has received CPR and the other things. So going back to the quality of life that you mentioned, if we're partially coding people and a code is taking longer, and yet the patients are still coming out of this code, we're not really giving them the best chances of future success. You're giving them it's almost like you're giving a family a pass as to what's going to happen. And it's a double-edged sword because we're the ones allowing this, so the family is going to do this because nobody wants to make the decision of, yes, my loved one should be a full code, let's do everything to know I don't want anything done to my loved one or to myself. And then it becomes an issue because like you mentioned before, the main thing is the quality of life that has to come to play to this. Because you're not going to try your hardest to bring somebody back from cardiac arrest, then is there really a point of doing it if you're just delaying the whole almost dying process in that sense?
Yeah, and reflecting back to that specific situation that this happened, this was more of a respiratory code where quickly just happened, Brady down. We couldn't figure out what was going on. We were doing meds only, so no CPR, and we had a hard time bagging her. You can tell that air is going into the stomach. We called the son, and he agreed for the intubation because she was a DNI. After we intubate, we've realized that she had a crazy mucus plug. They were literally suctioning out the airway in between breathing her to get all that out. Okay, we found out the problem. But this took 10 minutes between a phone call to getting her intubated, finally to establishing a good airway. How much brain cells or cell death happened in that time where we didn't have an effective airway, weren't perfusing her, and weren't doing any circulation. So both cardiopulmonary resuscitation in that situation was just taken away. Okay, now we saved her, but what's going to happen? Back to quality of life. Well, she's going to have a anoxic brain injury for being down for too long. We saved her life, but this happened. You never tell the family that this could have been prevented if she was just a full code, if this situation were to arise. And that's where the trickiness things happen of doing partial codes. For example, the BiPAP situation. We're only waiting for the worst to happen, and now we're not going to be able to do the airway. So what if we just transition to comfort care? Maybe it's a conversation. There's two aspects to this dilemma. There's one, the family that won't let go, and then there's the doctor that maybe is not explaining the disease process correctly of what's happening. You can tell somebody they have cancer, whatever, they'll still intubate them, and we're just going to have them on full support to the family decides to transition. So I would love to work day shift to see these conversations play out with palliative or whoever's happening. I want to know, and that's why we've done night shift for so long, is how are these situations going on? What's happening? And I'm reflecting back to one situation. We worked days for one contract in 3 months in LA. I had a patient who had cancer. Palliative came in and had a conversation. Palliative walked out. Patient still asks me, what's full code? What education was provided to this family? And that's where things bother me. So what's the gap that we have? Too little time with family spent and explaining the situation, or is it stubborn family? I'm sure it's a combination, but it just creates way too much of a gray area. Then you play with code statuses and you have bad situations, and ultimately the patient suffers more than anything. And that's when you have that compassion fatigue when you're seeing all this play out.
Yeah, I'm not sure if your opinion has changed about these partial codes. But mine definitely has. I know
Yeah.
when I was a new grad, maybe the first couple years of my nursing career, I was completely open to partial codes. I was like, yeah, it's whatever the family wants, they should be able to have. Whatever the patient wants, they should be able to have. But then over the years, after seeing a bunch of codes, partial codes and full codes, these partial codes really don't work very often. Rarely. They rarely work. Maybe they work if you start them, you could say, before the patient cardiac arrests. Like sometimes you might they might be braiding down and being hypotensive, so you might put them on like a epi drip before they fully cardiac arrest. But once they cardiac arrest, if you're not trying to do every single measure possible, it's really hard to bring somebody back. But now when you look at the flip side, the people that are probably for partial codes, it's different when you haven't seen a code actually happen and you haven't seen somebody actually do compression on somebody else, because somebody is literally using both their hands and a good amount of strength to get your heartbeat to start working again. A lot of times bones get broken, sternum gets broken, and it's a messy process. It's not very pretty. Sometimes they start bleeding orally. Sometimes when you intubate them, you just see blood coming out because we've been doing compressions for such a long time, doing everything that we can to bring it back, where it's gruesome, where I understand that if a family member sees that happen to their loved one, maybe they don't want to do a full coding, when they want to do just no CPR. But it's one of those things where you're just kind of being picky.
Side note, did you ever eat the Crunch candy bar?
Yeah.
So there was a meme when giving CPR, that's how it feels.
Dude.
When you're taking a bite, it makes those crunches. When we're cracking the chest, that's the crunch that we're experiencing when the sternum is cracking.
Yeah, and it's not fun. You're just like, oh, and you know you did it, and you're like, wow, now this poor old lady, not only is she going to have a long rehab process of cardiac rehab because we got her pulse back, now she's going to possibly need some kind of a surgery or might need some kind of a plate in her sternum in the future if she pulls through. But the thing is, like, why would you not, if you're going to give somebody a chance back at life, why not give them the full chance? That's what it should just be between a physician and a family. It's just, hey, do you want us to do everything or do you want us to do nothing? Do you want to give your loved one a full chance of coming back, or do you not want to give them anything at all? Because this partial stuff, like I said, over the years, I've noticed that it doesn't really work very well. And it's more of just like those picky things that either leads to just a prolonged hospital stay where the patient ends up dying anyways, or it just doesn't work.
Yeah, this sounds like I don't want to say it so bluntly, but almost seems like healthcare is throwing family members breadcrumbs to just delay the situation from happening.
Yeah,
sometimes they don't know how else nicely to put it.
Yeah, sometimes more options isn't always the best. I know we like to have different flavors of ice cream, but code status is probably not the place to have multiple flavors.
Yeah, and there's also the other dark side of having a full code patient. This was in Texas, where the patient was intubated and brain death was announced on CT scan, and family still wanted to keep them alive, and it turned into like this whole financial case thing opened up, where the ethics committee had to get involved to say that this is not appropriate. How can you have somebody like 20 days on a vent? It's when you walk into the patient's room, it smells like a dead corpse. Like, I don't know how else to put it. I got chills. We had to open up the window, and usually all the windows are, on the lock, and we're trying to air the room out, and we're still. And it sucks because you're coming to work and it doesn't feel as rewarding because you're doing something that's ethically wrong. Yeah. And you still have to kind of provide the best care you can in this situation. So that's the other full spectrum with dealing with family, having a full code, and the family just doesn't understand to let go of the patient.
Yeah, and sometimes there's a feeling that, like, for example, the patient you're talking about, when you enter a room like that, you almost feel like it's just the body in that room. The person that was in that body is now gone. And sometimes we even feel that when we have patients that were post code and maybe they're still in the hospital for a month, there's still some brain function, but that person's not going to be the same ever again. So when you just enter a room and you just feel that this person just is not there. Yeah, heart rate's in the 70s, 80s on a monitor. Yeah, he's getting 22 respirations per vent. Yeah, he's circulating with a MAP goal of 65 plus without his medication, but minimal brain activity, he's not going to be the same. It's just, you just feel that soul is now gone out of that body, and it's just there. It's just, that's what it feels like. It almost feels mundane. You walk into that room and you have almost like no emotion. You feel sad, but it's like what are you feeling sad for? Because there's nothing there besides a body, which is kind of crazy concept to think about. I think about it like that, but that's just how it feels sometimes.
Nurses are becoming the next vets, as well as that sounds, because of the PTSD that we're experiencing, and that's just the added on flavor when you join the ICU. You see, or you might see it on the floor when things are happening, but usually they get transferred down, and then we deal with the heavy ethical issues that happen in the ICU. So a fun little concept that we looked up is how much time do we actually have till brain damage occurs. So during a cardiac arrest, when we're initiating CPR, we want to start it within 2 minutes. That's because the third minute that reaches, you're going to have global cerebral ischemia because of the lack of blood flow to the brain, leading to the brain injury. And it gets progressively worse. After 9 minutes, you have severe to permanent brain damage. And after 10 minutes, there's low chances of survival.
And even if you bring them back after the 3-4 minute mark, the chances of them leaving the hospital are very slim. I think it's like 80% of people that code end up not walking out of the hospital. So that's why we always want to negate a code situation. We literally want to do everything to prevent it. And the crazy thing is, now you have, we talk about the whole episode, if you have these partial codes. So it's like, you can't, man, because your instructor was also not fond of these partial codes.
Yeah, he said it's unethical.
Because it's like, it's either you have 2 feet here or 2 feet there. That's what it is. And like I said, it's the issue is with the physician and the physician communication with the patients. Has to be. It's just one of those things where we talk to the family. They're not sure if they want to do a full code or not full code. So we just kind of throw in that, hey, we could also make them a partial code if you're not really sure. And maybe we're probably doing a disservice. Because think about it. It's either we do everything we can to bring it back, or we don't do anything. And that's the way, unfortunately, how things are.
Yeah, and
can't be picky with this thing.
You can't be, and also as a healthcare provider, the family and the patient deserves to know things in real time to potentially change code status to prevent things from getting worse or having a serious complication where you're going to have a decreased quality of life if we do bring you out. So it could be a full status. All of a sudden, you maybe get a pneumothorax. We put a chest tube in, BiPAP. Things aren't looking good. He already has lung to the Mets. What are we doing here? He was a full code. We're trying to do chemo to save his life. Now, within this hour, 3 hours, he became obtundant. The course of direction has to change. We need to intubate him. But he has lung cancer. He doesn't qualify for the transplant list. What are we doing here? Let's be honest. And these are the conversations that we need to have as a physician. I feel like some physicians are a little bit soft too. I'm not gonna lie, calling it out what it is. We have to be more upfront and have these serious conversations as things are happening, because when you talk to these patients, they really don't know what we know. There's such a disparity in the gap of knowledge, and even discharging patients home, we give them a pamphlet and we assume that they're not going to know how to take care of their CHF or their diabetes, and they come back and they don't know how to use a glucometer, and it's just the reality of life. We need to get better at bridging that gap of knowledge.
Yeah, I'm glad you brought up the part about the physician being soft, because that's so true. That's so true. There's a lot of times nurses keep trying to get this code status reversed, and the physician either doesn't want to talk to the family a second or third time. And I kind of understand it, because I'm sure they would think about it differently about the patient on a ventilator that's just getting by with the machines if they actually spend a lot of time with these machines. Physicians, they have a high patient load. They're in and out of rooms. They're just assessing and then reacting to whatever the patient is doing. They're not actually with the patient 24 hours a day like nurses are, or 12 hours a shift, depending on how your cycle is. So it's different when you actually have somebody that's a full code, but on all this life support stuff that you know that is not going to walk out of hospital, that you know that the brain damage is already done, and you want to give this person, let's just say, a peaceful passing, and you can't, but you keep telling the physician, hey, I think it's a good time to talk with the family again. There's nothing we could do. He's around 3 pressures, this and this. It's imminent. The code is imminent, and he's already having this brain damage from the anoxic brain injury that he sustained from the first code, and we're just waiting for him to code a second time, because if you code a second time, your chances of survival are even lower. But we're just waiting at that point. And it's a lot better for us as nurses and even to family members if you just let that person go peacefully. And physicians have to facilitate that. And it's true, some physicians are soft. They don't want to address it over again. And sometimes they're not soft. They just don't understand what it is to have just a body there on a bunch of medications on these machines just laying there, and you're just doing work around it when you know that that person's not there anymore.
Yeah, and this is not coming after physicians.
Well, it's not, yeah.
And I'm thinking about it too, where they have so much patience, they put in so much orders, they keep going in and out doing tasks where sometimes the human part disappears too. We deal with patients bedside, and sometimes the humanness disappears too, and we're not communicating, where we're just too busy hanging meds, going from room to room, and don't have time to hold somebody's hand and tell them they're doing good and keep on fighting. So if we have that and we do bedside, imagine how the doctors feel. Like, you make a good point. It's all numbers sometimes and lab values, and the humanness gets taken away, and we don't have the ability to critically think and say and stop this. And like, also the whole dilemma of, it's not, how do I want to say it? It's not pleasant talking with family when they're in such a high stress, and we're almost like we avoid it, or we don't want to pick up the phone or make that phone call to the family. I'm sure doctors feel that way. Sometimes getting updates from family is not the best, especially when they're not annoying, but just super anxious about things or don't trust us, and it makes things harder. So, imagine that. Imagine if we just picked up the phone more often to make things happen. So that's just all improvement that we can do in healthcare, as we discuss every episode, just sharing the insight of how we could have a couple of nurses hospital here to make some great changes, actually make it run properly, because there's so much that we see that could be fixed from all the facilities we worked at, right?
Yeah, or even I was talking to one of the nurses here, and we talked about it before when we used to work in Austin, about nursing run hospitals. But of course, if you want a nursing run hospital, nursing school would have to incorporate more of the finance classes, the business administration classes, and some of that they don't offer.
Yeah.
For nurses. I wonder if they offer that for physicians. Do they have like a class like that helps them with finances and how to start an office or a clinic? Or
who knows, man? My uncle got a business degree, and they didn't even teach him how to open up an LLC and run a business. So I could only imagine what curriculum is for finance.
Yeah. But we all need to do a better job with this code stuff. It's very touchy. It's very difficult because we are talking about someone's loved ones or even our own patient. Because it's always, one of the scariest things ever, or one of the most nerve-wracking things that you're gonna experience as a new grad is when you're not sure what the code status is of the patient, like for admission, and you have to ask the patient, "Hey, do you want to be a full code? What would you like us to do in case your heartbeat stops?" And sometimes they're gonna be like, "Oh wow, I never thought about that." Yeah. Or, for example, they have never thought about that, and now they come to you intubated on a bunch of pressures, and you got to call the family and tell them, "Hey, we have your son. He's on 3 blood pressure medications to keep his blood pressure up. He's being ventilated by a machine. And what would you like us to do? Do you think your son or loved one would want us to do everything in our power to bring him back if he was in this situation?" A lot of times the patient or not the patient, but the family is going to be like, "We never thought about it. We never had that talk." And it's like, damn. It's always kind of awkward and kind of sad because sometimes they ask you, "Hey, what do you think the chances are of my loved one coming back out of this?" And it's always super hard answering that because they're so reliant on your answer. They want you to provide some kind of glimmer of hope, or they want you to answer that question for them, but you can't. It's so hard to do because patients always ask, patient's family always asks, "What are the chances of my loved one coming out of this? What would you do? What do you think? You've seen this multiple times. Do patients come out of this?" And it's always the hardest thing to do. I try to be honest, and a lot of times that honesty is me saying, "Yeah, I've seen many people in this situation, and not a lot of them come out, and sometimes a lot of them that do come out aren't in the best shape to begin with, and a lot of times they end up passing away a couple weeks afterwards."
Yeah, and you're just being a patient advocate at that point, and I know we're supposed to refrain from doing that, but that is really the right thing to do, is to give some feedback in your experience of how the situation is going to play out. And I feel like we have that time versus the doctor when we could be honest and blunt about it. And ultimately, the families, you're giving honesty to the family and the patient, and the patient's wishes are going to get respected more at the end of the day because they want quality of life. And I feel like we can be great advocates for that and help with code situations or statuses and help facilitate that, even though technically that's not our jurisdiction and we're practicing outside of the scope of practice as a nurse. It's okay to answer some questions or provide a little bit more perspective or feedback of what they can expect, because we can do a better job than doctors. Straight up. We see it, we live it.
And to be honest, when I do talk about the code statuses with the patient family, is I'm probably going to change up my routine. I usually give them the option of a partial code. I usually say we could do everything in our power to get your loved one back, to resuscitate them, or we could do nothing and have them pass peacefully. And I always give them a third option where it's like, or we could do, for example, no CPR or no intubation and meds only. And then they start thinking. I think I'm just going to lay forward maybe just 2 options. And if they want more information, then to just talk to the physician.
Yeah. I like to break it down a lot when they are intubated and they're thinking about getting a trach. And trachs never work out well, meaning there's patients that have it reversed, but a lot of times they come in and out of the hospital to us for pneumonia from nursing homes, and they're just miserable, man. I hate sputums and trach and all that, just seeing somebody cough, me needing to stick a damn catheter into their throat or whatever, their trachea to suction things out. I don't wish that for anybody. Not even myself, guys. I don't want a trach.
Whoever invented the inline suction, that's clutch, because imagine having to just like nasopharyngeal suction people, and you're always healing that gurgle, and you're always seeing that stuff, because the inline is less gross, because inline it's not as messy. So that's shout out to whoever created the inline suction. Yeah. But for you personally, would you advocate for a partial code, or are you anti partial code?
Well, see, I don't want to.
Or just something you don't want to say.
I'm gonna speak. I just hate the whole left right. I can be in between. JK, this ain't that kind of situation.
Isn't between here right now, bro?
I know. I'm really vouching for not having partial codes, and just like all the scenarios that we explained, there's things that can maybe change. Like, okay, if they're intubated, we could do the D in our DNI because that means we're not gonna do anything else. But if they stop coding, are we gonna just do meds? Okay, so back to that. Yeah, it has to be just one or the other. It's just going to be beneficial ultimately for the patient and for healthcare not to confuse things and have a better,
Once you start introducing gray area into this, it becomes even grayer, murkier. Because like you said, for example, somebody says no CPR, but they want to be intubated and they want meds. So then if that's all they want, and then we proactively intubate somebody, and then during that intubation process, they lose a pulse, do we stop there? Do we stop intubating and don't do CPR? Because technically we're already intubating, and since we try to prolong their life proactively by trying to intubate them, now they lost the pulse. So it does happen. I've seen a handful of situations where we proactively intubate somebody because we think he or she is going to code, or we just need to give them better respiratory support, and during the intubation process they code, and then we're hopping on a chest. So that becomes super murky, because if there were no CPR when they lose a pulse, and now we just try to intubate and they lose a CPR mid-intubation, do we continue with the process, or do we just say, hey, no, never mind, we're pulling the ET2 back, we're not doing anything? Right? It becomes very, very confusing, and even darker and darker and grayer. So then the line keeps getting pushed further and further up until there's all different types of codes. We're only going to allow this medication for the code. We only want our loved one to have only epi. We don't want any other medications like amio or lidocaine, or we don't want any kind of cardioversion. We just want straight meds, or we just want cardioversion but no intubation, no CPR, and no meds. It's just like whoa, like hold on. And then you're gonna have mistakes happen because we wanted to satisfy the client. We are a service industry, but we're not a hotel chain. We don't just cater to the patient's family, whatever they want, or the patient every little thing. When someone gets put on a statin, let's just say like 50 milligrams or whatever, patient doesn't just say, no, I'm on 25, so give me a prescription for 25. We don't say that. right? So why are we giving these kind of great options to people that are not fully educated and don't fully understand this whole resuscitation process?
Yeah, and let's throw in the POLST form, which we're not really talking about. Is it called POLST, right? POLST. When you discuss different treatments for the future. So on top of code status, you have the POLST form, so you can see if you would like artificial nutrition, if you want to get dialysis and the other stuff. And that has to be assessed too in real time. If you're a full code, but then on your POLST form it says DNR, okay, well, in about 3-4 days, the kidneys are going to go bad and you might have uremia or hyperkalemia and you might code. So now let's probably make you a DNR if you don't want to get dialysis. And yeah, like we can talk about this forever. It's just murky. It has to get solved and it has to be per patient basis, but definitely playing around and picking and choosing doesn't work out because it doesn't provide great care at the end of the day.
Right. Yeah. It should all either be 2 feet in or 2 feet out. So we do everything we can or you don't do anything and you just go on your own.
Exactly. So that's just our perspective. I'm sure you have your own opinion, and if you do, you can share it on our Facebook group or drop a comment somewhere. We're open to engaging and discussing.
Thank you so much, guys.
See you in the next one.